Good evening, everyone. Good evening, everyone. And welcome to another session of Let's Talk About Cannabis and Healthcare. My name is Drudis, and I'm your host. I'm a registered nurse, a healthcare strategist, the author of Healthcare Cannot Manage What It Cannot See, and founder of Project Destigmatize Healthcare, a research nonprofit in the healthcare visibility space. Thank you for spending time with us today. Every conversation we've had in this series starts with the same belief. Healthcare can't improve what it first cannot recognize. And sometimes what healthcare cannot see is hidden inside our data. And because it's hidden inside our workflows and it's hidden inside our education, we can't have the conversations, and we're afraid to have the conversations that we need to have. And cannabis has become one of those very prominent conversations. When providers feel prepared, or when they don't feel prepared, they need to start having the conversation. Patients are already using cannabis. They're using it for chronic pain, for anxiety, for sleep, for cancer and chemo symptoms, for neurological conditions, for quality of life. The question is no longer, should healthcare pay attention? The question is, what is our responsibility now that it's here? So today's session asks that question that extends beyond cannabis. What it really applies to every emerging therapy, really, every new technology, AI, nootropics, every new behavior, every change that enters healthcare before our system is fully prepared is essentially under surveillance right now. So today's question is pretty simple. When does knowing what the patient is doing become a patient safety issue? And to help us explore that question, I'm honored to welcome Dr. Tishler to the stage. Thank you. Thank you. You've dedicated your career to endocannabinoid science. And I'm actually going to move a little bit further up. In every conversation that I've had so far, everyone has a story about how they're coming into this. So Dr. Jordan Tishler, I'm first going to introduce you to our audience. You are the president of the Association of Cannabinoid Specialists. You've trained and served on the faculty at Harvard Medical School and Mass General Brigham, where I started my nursing career. You've been recognized nationally for your leadership in cannabinoid medicine, as well as clinical education and patient safety. Dr. Tishler's work focuses on helping clinicians responsibly care for patients using cannabis through rigorous science, through thoughtful clinical judgment, and compassionate care. So welcome, Dr. Tishler, to Let's Talk About Cannabis and Healthcare. We're so glad that you're here.
Well, thank you for having me. It's wonderful to be here, and that was a lovely introduction. Thank you.
Oh, you're very, very welcome. So I want to just jump right in because a lot of times we don't know what brought people to this career. So I want to start with just kind of, how did you get into this, and what was your journey into this practice?
Well, what I tell people actually is that my background, my training was pretty much as conventional as it gets. So, I went to Harvard College and I went to Harvard Medical School and I trained at one of the Harvard hospitals. As you mentioned, we have this running joke that if you went through Harvard 3 times, we call you Preparation H. We don't want to take ourselves too seriously, but after training, which was, as you mentioned, in internal medicine, I actually didn't practice primary care, which I had thought I wanted to do, but I actually found myself drawn to emergency medicine. And I practiced emergency medicine for about 20 years. And the last 15 of those years were through or at the VA in a nearby West Roxbury, which was the major hospital for New England. And, I saw all kinds of stuff, as one does in an emergency department. But what I saw over and over and over again that was really disheartening was patients who just kept coming back with substance-related issues. And really, when I say substance, I really mean alcohol, right? On the top 10 list It's sort of 1 through 9 alcohol, and maybe at the very bottom there was a little smattering of benzos and opioids, but really alcohol was the major culprit. And back in 2011, when Massachusetts started talking about medical cannabis, I think I, like most of my colleagues, said, medical what? Right? Like, what are we talking about here? Obviously we were all aware of its recreational nature, but the idea that it was a usable medicine was kind of an interesting idea. But then I had my sort of aha moment where I went, well, I've seen all of these patients who have been so harmed by these other substances, again, mainly alcohol, and I've never seen anybody sick from cannabis. So maybe that says something about the relative risks, and maybe I should learn something more about what cannabis could be useful for. You may remember way back when there were people running around like Mrs. Clinton, for example, who were saying medical cannabis is a lovely idea, but there are no data. Well, it turns out that way back then, if you put the word cannabis into PubMed, which is kind of the Google for science, you would get a mere 25,000 studies. Right. I mean, that's an enormous number. And for comparison, if you put alcohol in, you would get between 5,000 and 6,000 studies. So it turns out that cannabis was, and still is, the most studied substance on earth. And the idea that there are no data is just not looking at what's available. Now, it turns out that not all of that data are useful. Some of it is biased because it's looking for harm, right? A lot of it was funded in the 80s and 90s by NIDA, which had a particular agenda. And a lot of it also was just not very well done. But if you, as I did, sat down and spent a couple of years kind of wading your way through that, I at least came to the conclusion that cannabis was a well-supported medicine. And by medicine, I mean it very specifically as a substance that can be used carefully and thoughtfully to have a good outcome or potentially good outcome, or it can be used thoughtlessly and carelessly and you can have bad outcomes, right? All medicines are like that. If you use them properly, hopefully things go well. If you use them foolishly, bad things happen. That's really my major position on cannabis at this point, is that if we're using this thoughtfully, we can make mileage for our patients. And if we're not using it thoughtfully, or potentially people are just kind of winging it, then sometimes bad things can happen.
That is so important, because I think when I look at healthcare, I think patients are already using it, whether we know it or not, right? And some of them are having positive benefits, and they're not talking about it. And some of them are having negative impact because they're not using it properly. So that's kind of like the general agreement in healthcare. But we also don't talk about Bruno. That's like the joke for me, is like we know cannabis is there, but we don't talk about Bruno. So from your perspective, what is a physician's professional responsibility in that reality, where there is the years of biased information, years of propaganda, and now this new information or acknowledgement? I wouldn't say information, because we've known it's good for some people, but this new acknowledgement that it has medicinal value. What is the professional responsibility when something like this happens?
Well, I think that there are kind of two different cases here. There's sort of, on the one hand, kind of the primary care case. And then on the other hand, there's sort of the cannabinoid specialist case. So for the primary care folk, I think that it's absolutely imperative that they become educated. But it doesn't necessarily mean that they need the level of education that would lead to sort of prescribing this medication. I think that we all have to acknowledge that primary care is a vastly oversubscribed, field at the moment, where they barely have time to spend having a meaningful encounter with their patients on a wide range of issues. So the idea that they would sort of kind of know everything they need to know about cannabis is probably just biting off more than we can expect them to chew. But to your point, I think that they need to be educated to the point at which they can say, for patients where this is medicinally applicable, Mrs. Jones, I'm not the expert on this, but I think you might benefit from cannabinoid treatment, so I'm going to refer you to somebody like myself, right? So that's kind of one approach. The other is, as you say, that many patients come in already using it for better or for worse, and that clinician absolutely needs to be able to address that, to say in a non-judgmental way, what are you doing and how are you doing it? How much are you taking and that sort of thing. And then to be able to fit that into a context which says, oh, well, that's fine. No issues. I'm glad you're getting benefit. Or maybe even, you're being overly cautious and maybe a small increment upward might be better. Or, recognizing that people could be taking too much and that it could be having some harmful or harmful effects, or be sort of leading in that direction, right? Because obviously we would rather prevent than respond to problems, and be able to coach that patient in a, again, supportive fashion, to decrease the dose and to a more healthful range. So that's kind of the primary care side of things. And then I think that there are other people like myself who want to dedicate themselves to this field, and they really need a lot more education. And that's something that my organization, the Association of Cannabinoid Specialists, can provide for them. But back to the primary care guys, I realize I'm being a little scattered here. We have a course aimed at them as well, right? And it's really focused on what we call recognizing and intervening in cannabis misuse, right? And it's really focused on recognizing the issues, understanding the consequences, understanding ways in which current thinking fails us. For example, the current definitions of cannabis use disorder are not terribly helpful. And most importantly, developing the alliance or rapport with the patient so that over time, meaning not on day one, but after you've gotten to know the patient over a bunch of visits, you can start to address these issues again in a supportive manner, which is the way in which we think change is best accomplished.
Yeah, no, that's so helpful. As you were speaking, I was thinking about the one patient incident that made me kind of go and want to go a little bit deeper. I've been a cannabis patient for almost 11 years now, and I, started after having postpartum. But as a clinical leader, we had cannabis patients coming in and out, and typically we would just confiscate their Schedule Ones and send it home with their family, or we would lock it up in the narc drawer and then give it to them upon discharge. But I had gone back into, I went from being a medical ICU director to a long-term care and rehab director. And in those places that people live there, and it's a very different environment. And we had a patient who was a veteran and was on his veteran benefits and was having edibles at night, but he was also newly started on warfarin, and we just couldn't get his INR together. And after like 5 different ER visits, somebody finally said, hey, we should check a tox screen, and kind of did that process. And when he came back and I asked, why didn't you tell us? And he said, do you want to get paid or not? I would lose my veteran benefits if I had told you, right? And then it made me think, even if he had told us, right, nursing wise, if he said it, we don't have an assessment to kind of like evaluate or guidance, again, because the harm reduction pathway is not the same. You can document social drinking, but you can't document social cannabis use. There's like no positive spectrum to the harm reduction pathway. And then there is no, like, some of the nurses were afraid to touch canisters of cannabis. There's no education, even with clinicians, because a lot at my age, we're a lot of dare babies, and there's a lot of misconception of drug use. And in the nursing population here in Massachusetts, we have a very diverse nursing population. And a lot of them are just like, no, those are drugs. And they've never even heard of the endocannabinoid system. And
Sure.
then I said we had no policy, we had no like we had nowhere to really put it. And even if we knew, pharmacy would have never known to do a med reconciliation. The physician would have never thought to, like, we just didn't have the infrastructure to support knowing. And I think and on the nursing side, we're very much a lot more progressive. I'm a member of the American Cannabis Nurses Association, and we just submitted a proposal for cannabis education to the American Nurses Association at their National Assembly in June. And they accepted it. So the American Nurses Association is going to be deploying cannabis education to their 5 million members nationwide, which is amazing. But then where are they going to put this information? And how is it going to be meaningfully useful in a medical record if we need to evaluate med interactions? And I think that that's what I'm struggling the most as a clinical leader and kind of like an operational mindset. But I also know that clinicians at the front line are struggling to even start the conversation. So, from your perspective, where do you see the tension or the struggle coming together when you're having this conversation with your colleagues, per se? Because I know you go to grand rounds and you go out there and you're educating. Like, where are you feeling the friction in this, in the information gap and wanting to know more, wanting to care to know more?
Well, I think that the education that the American Nursing Association is going to put out, I think, is a really good step because, as you say, it's not going to slot in perfectly with the way medicine is practiced now, but you got to start the conversation somewhere, right? And that those systems will mature and accommodate as more nurses and other clinicians start to learn this and start to understand the ways in which the systems aren't supportive yet. On the physician side of things, it's been interesting. I find that most doctors are generally supportive and mildly curious. But what I also have seen is that here in Massachusetts, and I'm sure this is true elsewhere, that after we voted in recreational legalization, not only did the number of card carrying patients dwindle, but interest in cannabis education has dwindled also. And I think, for clinicians for whom this is not sort of their bread and butter, it's just, it was on their radar, and because patients stopped asking, it's fallen back off their radar. And, while I conceptually agree with the idea of non-medical legalization for reasons of, personal freedom and obviously mitigating some of the racist issues around disproportionate enforcement, generally speaking, from a clinical point of view, meaning for people who would benefit from this medicinally and for whom the guidance of a knowledgeable clinician is kind of crucial, recreational legalization has not been a positive, right? Because it has allowed both the marketing and the mindset to go in the direction of, oh, I'll just pick some up at the store and everything will be fine, so that it's not coming up with their doctors. It makes it more hidden, if you will. And those same patients, whether they're using it for sleep or back pain or whatever, that really would benefit from talking to somebody with knowledge, aren't doing it, right? It costs money, it takes time, right? All of those sorts of barriers that are simply higher than I'll just go get a joint, smoke it. So
Yeah.
that's a negative, I think.
Well, interestingly enough, that's kind of what led me to found Project Destigmatize Healthcare. It was the idea that I went to colleagues and I was like, and people were just like, "Where's the evidence? Where's the data? And as you mentioned earlier, we have a lot of information, but a lot of it is not necessarily useful in terms of the way it impacts and applies to like the reality of human consumption. We don't even really know what normal consumption is. We don't have any prevalence data on what people are actually doing. So I wanted, and that's also because a lot of research defines cannabis use as once in the last 30 days. And I think that that's not how everyday consumption is happening, at least from my perspective. I am a daily consumer. So it's like I wanted to get to the bottom of it and just really create some sort of data that says, hey, guys, people are consuming on a regular basis and in enough cadence that is we have a polypharmacy risk. So we should be talking about this. The other thing was they're also not disclosing, or they're disclosing, but somehow it's not ending up in the medical record. There's a study I reference often that says that, we know that 30% of adults are consuming, but only 0.4% of medical records contain cannabis or the word cannabis in it. And typically it's cannabis use disorder or cannabis hyperemesis syndrome, cannabis dependency. It's never, therapeutic cannabis use, right?
Right.
We don't even have the language for that. So, and the last part was just frankly asking the same consumers if if they felt side effects or adverse effects when they mixed their meds with their cannabis. And like 40% of people were like, yeah, I had a weird feeling, an unintended feeling when I did that. So like it was interesting to see that three things stood out. One is that the adult use dispensaries have become de facto patient access points. 79% of the people that have taken the survey have said that they're using it for therapeutic reasons, but they're accessing it through the adult use dispensary. And that brings your point to the forefront, is that where's the education for the adult use industry, and where are the guardrails for product marketing and development that align with how therapeutic cannabis use should be happening. The same way that we have guardrails around, I don't know if you've read the tough study on cannabis hyperemesis syndrome, and they're saying it's they've seen an increase, but we don't really have any baseline data, and then we also don't have any other information other than it's happening. We don't know what products are causing it. We don't have, we're not collecting the public health surveillance data to try to capture this as maybe a concern, to build better guardrails around the industry, and really just to learn as we're growing as an ecosystem.
I think that we are collecting that data. It's just ill-defined at the moment, and it's taking time. I think you're very much on point that the fact that we're seeing more of it doesn't necessarily mean that it's happening more often. It means that people are coming into the hospital for it, or people are admitting to us what they're using more. And now we're connecting dots that we didn't know even existed before. Or maybe it's actually increasing, and maybe that has something to do with the increasing in potency of the THC in cannabis flower. Or, there have been hypotheses that there are certain pesticides that might be relevant. There's a lot to be teased out there. Thankfully, it's just not, despite the sort of what's the word I'm looking for? The hype in the news media, it's still fairly uncommon. I encounter patients who have this diagnosis fairly frequently, but in my practice, I have only seen it twice, and that's over 15 years and tens of thousands of patients. I suspect that, like most things in medicine, and more specifically in the cannabis world, that it's going to be a dose-related issue, right? And if you are somebody who's using cannabis therapeutically on the daily, but you're using it in a very dose-limited fashion, meaning sort of an average of 10 milligrams, maybe twice a day, I think it's very unlikely that we're going to see those problems develop. On the other hand, if you are the sort of person who is smoking, say, an ounce a week, I think that that's a very large dose. Remember that an ounce of 20% THC contains 5,650 milligrams of THC. That's a far cry from 10 milligrams a day. So I think, we're going to start to see that shake out. And your point is well taken, that we need more studies on this so that we can really define where the problems lie, so that we can then respond by educating not only our clinicians, but our patients as to what are healthy behaviors versus which are potentially dangerous behaviors.
Yeah, and I think that that's so critical, because I think a lot of the information that's coming in to patients is coming in from marketing and not from science.
Right.
And then it's important to like balance the scientific rigor and want more information, but also care for the person that's in front of us, and have good clinical judgment. And I think that we just have not been taught to look at cannabis patients as patients that could potentially be therapeutically using the substance in a way that is dose controlled and is actually benefiting their life. And I think that that's the destigmatizing that we have to do in healthcare, just breaking that barrier, because it then impacts populations that are traditionally underserved already and already facing a lot of health equity issues. And I always try to remember that those dots connect, and it's typically the people who are most vulnerable that are the ones that are most at risk.
Yep.
And that's when I was thinking, the safety risk that is before us, it's a preventable clinical risk if we have the conversation.
Just like opioid crisis, I mean, the bottom line is it didn't take rocket scientists to see that problem coming. We just didn't do anything about it, right? And what we have sort of brewing potentially with all of the marketing that you're referencing is a cannabinoid crisis, right? I mean, if we, the marketing kind of goes like, well, alcohol is freely available and cannabis is safer than alcohol, right? And it's safer than opioids. And somehow the word safer gets translated to safe, right? And it's not true. I mean, it is true that it is safer than alcohol and it is safer than opioids, but that doesn't mean that it is 100% safe. And that marketing really misleads people into this sort of more is better mentality. And that's how we get into trouble as individuals and as a society. And now more than ever, unfortunately, with our current national politics, we don't do nuance very well, right? It's either terrible and it should be illegal, or it's wonderful and everyone should have it. And honest to God, one CEO once said to me, it should be in the water supply. I'm like, yeah, no, right? It's in the middle, right? We have to be thoughtful and careful and acknowledge that there's benefit and risk, and you get benefit and avoid risk if you're thoughtful and careful. I mean, it shouldn't be difficult, but it is.
No, we're so aligned. I appreciate that, because I always say it's not for everyone. It benefits a lot of people, and you should have free access to it, especially if it's something you can grow. You should be allowed to grow it in your home if that's how you choose, because that's part of like the therapeutic impact too, just really creating your own medicine, especially in cultures like mine. I'm Caribbean, Afro Latina, and it's part of like how I grew up. I grew up on leaves. So I think like the education is obviously missing, but I wanted to focus on what you believe, like the basics of basic understanding. If someone is watching this episode, it's like, where do I start? What is the basic understanding that a provider should be trying to have about the endocannabinoid system? And where would you guide their curiosity first?
Let me ask a clarifying question. You want me to talk about docs or patients here?
I would say let's talk about docs. You're a doc. You're kind of leading the conversation with the docs. So if you have the young docs in front of you, where would you want to point their curiosity?
Actually, that's a relatively easy question for me because it's the organization that I run, the Association of Cannabinoid Specialists. And what I would say to them is, look, we're a not-for-profit. There's no, personal benefit from my recommending this to them. But what we do is we provide a whole range of educational opportunities, right? And we have some that are really short and sweet and kind of get to the point, and then there are, medium and deeper dives. And so you can start by taking kind of small bites at the apple and kind of move further and further as you find the time and the interest. And I think that it is pretty basic for somebody who's not going to be an endocannabinoid specialist to start to understand that there is an endocannabinoid system and its role and function, and also to conceptualize that there are many systems in our brain and throughout our body that once we start to understand them, then we try to find substances, drugs, pharmaceuticals or medications that alter the performance of those systems and do so in a way that then provides a beneficial outcome for people who are ill. And the endocannabinoid system is no different in that regard. And it happens that the cannabis plant provides some of those chemicals with which we can thoughtfully and carefully start to bolster people's endocannabinoid system when they're having problems. I think that's really a very basic understanding. I think it's also important for those sort of those young or interested docs to start to think about who's already using it, and are they using it in a therapeutic fashion? Are they using it in a recreational fashion? And to understand that both of those are legitimate and that they pose slightly different risks to that patient, and that our job is not to sort of plug our ears and go la 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 la, but rather to get to know the patient, to understand their current use and their needs, meaning their intentions, and to support that in a fashion that guides our patients, again, to sort of the safest use, and to educate our patients about habits that may be problematic. Again, somebody who says, every evening when I come home from work, I have a couple of puffs on a joint to kind of unwind or whatever. That's not dissimilar to when my dad used to come home from his work in the hospital. He also was a physician, and he would have a glass of scotch, right? That kind of recreational use is legitimate. And if the patient is saying, I have a couple of puffs, that's probably within the safe zone, right? If, on the other hand, they say, I come home and I smoke up, an entire gram pre-roll, then there's a different discussion, which is not like you shouldn't do this, but rather, how much THC is in a pre-roll? Let's talk about that, and let's talk about the ways in which this can be not so good for your body. And let's talk about ways that you can use this that will be just as good for you, but safer in the long run, right? I mean, that kind of discussion, I'd like to think, will help patients avoid trouble and feel supported rather than stigmatized.
No, absolutely. I was just thinking of I definitely know some folks who can take a gram and probably need to use that entire gram. So I was thinking in my head how much we don't know about dosing, and how there is also there's a perception on there's no real individual data on what dosing should be, and I was just
I can
curious.
address that a little bit. What I have found after doing this for a long while is that I often had patients come to me saying, I've been a lifelong cannabis user for non-medical reasons, but now I've gotten to a certain age and say my back is hurting or whatever, and I find that the cannabis isn't helping as much as I want it to. And what I often find is that they're using a much larger amount than I would have recommended. And they got there honestly in the sense of like they've just been using it sort of without thought to dose for a long period of time. And we know that over time people develop a tolerance, and that the tolerance, if it gets high enough, can create things like dependence and sort of negative outcomes that we'd like to avoid. But what's really interesting to me is that with the patient that I was mentioning, or the few patients that fit that story, once I had developed enough trust with them, I was able, in many cases, to sort of convince them to cut back. And the interesting thing is that when you cut back, you undo some of that tolerance. You repopulate some of the receptors that have otherwise been removed to deal with the inflooding of THC. And when you get them down into a more therapeutic range, the interesting thing is not only are they safer and spending less money on their cannabis, but it works better. And suddenly they're saying, "Doc, you were right. My back pain is so much better." So I think that there really is some fairly well definable therapeutic range that I would say is sort of between 5 and 20 milligrams once, twice, or rarely 3 times a day. And then there's stuff above that I think people, how do I put this? They end up in those ranges simply because they've never really spent any time thinking about how much they're actually getting. And I think that there's also a cultural aspect, which is sort of, we never want to say, no, that's too much. So there's always this sort of mantra, everybody's different, which is true, but they're also, most people are within a certain range. And so it's very easy in cannabis culture for us to say, oh, well, he just needs that much. Well, maybe he needs that much, or maybe he's just stuck up there because that's where he's landed, but actually would do better on less, both in terms of safety and actually the effectiveness of the medicine for his problems.
No, that's interesting. I guess I've never really considered that perspective, and when people have had a ceiling, how it impacts. I often think that CBD is usually like the complement, like having a one-to-one sort of relationship with them, and starting low and staying low is kind of like what works, at least for me. And that's typically what in nursing we always say: start low and go very, very slow. Um, and I was thinking, even as this was happening, that cannabis is not, I don't know if it's the destination. I feel like it's the current case study, because we have new phenomenon coming into healthcare, into the world all the time. We have the rise in, people taking nootropics and other herbal supplements, and these industries are booming. And as they're booming, I think there's going to be an opportunity for us to kind of build some sort of infrastructure to capture the information as it's coming in, to establish some sort of baseline. So if we create the pathway with cannabis correctly, and we all participate in this kind of like building what it should look like for all practices and what it should feel like for the patient experience, I think that we really have an opportunity to like make the best of cannabis and the best use of this obvious phenomenon in our communities. A lot of patients are already consuming it, and we have the ability to kind of walk it through into healthcare in a way that's thoughtful. Because 5 years from now, it could be something we just hadn't even imagined. We could be talking about the impact of AI on healthcare, and we don't know. So I think, thinking in that kind of realm, how do we then decide that this new area of knowledge has crossed the line from being specialized expertise to like everyone should know about this. This should be basic professional competency that every clinician should possess.
I think that there's a theoretical or fantastical answer, and then there's sort of a more pragmatic one. But HIV is a really good example of that. As you're well aware, HIV medicine started out and was really in the field of infectious disease for a long time. And then infectious disease specialists further specialized in HIV, and really ran clinics where that was all they did. And then, over 30 odd years, that information became more commonly understood. And also the regimen settled down, right? I mean, back in the early 90s, there were very few drugs that were effective. And, it took a fair amount of understanding to understand which ones were going to be more likely to be helpful for this individual and to change them when things started to go awry. But now in 2026, there's a much more standardized cocktail, and it doesn't mean that there aren't patients who end up in a situation that exceeds their primary care doctor's knowledge, and then they go to the specialist. But diabetes management also, back in the day, if somebody had diabetes, they went to an endocrinologist or a diabetologist. And now most primary care doctors will manage some level of diabetes up until things become kind of too complicated. So I think that, if we are using our crystal ball and looking 20, 30 years from now, I think it's going to be common knowledge for clinicians. But I don't think it's going to get there, in short order. And I think a lot of that has to do with the fact that it's not 100% relevant to every patient encounter. And it's also, it's specialized knowledge. And primary care is so under siege at the moment in terms of the amount of time that they have to cover everything from pap smears to bicycle helmets, right? And in 10 minutes or maybe 15 if they're lucky, we've just set that field up to fail as it is. Trying to shoehorn in yet another area of medicine is just kind of asking too much. I would remind you that when I sit down with a new patient who comes to see me specifically for treatment with cannabis, I spend an hour with them, right? And that's on one topic, right? So the idea of compressing that into the same 10 to 15 minutes, along with all those other topics like blood pressure or, a breast exam or whatever, like it's just, we have to be a little bit pragmatic about this at the moment. And my hope is that American medicine writ large manages somehow to dig itself out of the hole that it's in right now, which really is about payment and insurance, right? I mean, I don't know any primary care doctors who enjoy having 10-minute encounter. I'm sure they would much rather have 30 or 45 minutes, or even an hour. That seems, truly fantastical. But, I think that most clinicians went into medicine because they care about people and they want to sit down and talk to their patients. They're just not allowed to by the institutions and the payment mechanisms. So someday, I mean, this is part of the reason I got into cannabis medicine too, was that I said, look, if I do this, I'm going to do this in a private practice because that's the only option. And if I do that, then I can set up the private practice so I can spend my time talking to my patients. And I looked around at a lot of other practices where, again, the patient might come in for an hour, but they would see the doctor for 5 minutes or 10 minutes. And then a nurse would do some education or whatever. And yeah, that increases your throughput and probably your revenue, but that's not the way I wanted to do it, because I said, I don't want to hand this conversation I want to have with the patient over to the nurse, because I want to have the conversation. I want that relationship. I realize that in that regard, I may be unusual. But I think that the point is, in general, if physicians had the opportunity to spend more time with their patients, they would take it. It's just not being offered at the moment.
Yeah, no, that makes sense. That's a very good perspective. Just I have a nurse practitioner as my primary care provider, just because I wanted that extra bit of time, and I'm in healthcare, and I knew that it would be a very different conversation. But as you were speaking, I was thinking, how do we arm the workforce to support physicians in that environment and still be able to capture some data, or do we just create like an like a very automated way to like capture some of this information or nuance before it even gets there? We have so much intelligence and technology. There's got to be a way to really just um, be able to capture the information to like prioritize some of the conversations that may need to happen. Um, I'm just dreaming out loud, I guess.
Well, here's what I would say. I think a fact that would shock most listeners is that even with prohibition and Schedule One, which were finally passed, the United States is still the number one producer of cannabis-related research in the world. However, not all studies are created equal, and there are studies that people might be sort of familiar with where they're sort of like a survey type questions. And so you get a group of people and you design a survey that asks them a bunch of questions. You ask them the questions, you get the responses, and then you start to look at how these questions map out. Those are very interesting and relatively easy to do studies compared to other types of studies. And these are what we would call an observational study, right? It basically says kind of what's going on out there. Let's ask and we'll get information. And we have a lot of that. In fact, we have so much of that in relation to cannabis that I think it's time for us to kind of stop doing that. But the problem is that there are a lot of incentives to do it because they're relatively easy to do. They don't cost a lot of money. They don't run into as much regulatory restriction as other forms of study. And of course, people need to publish as often as possible to support their career path. So we're seeing a lot of that kind of study. But the problem is those studies can't really prove anything, right? They simply describe a situation, but they don't tell us whether the description that we get is accurate, right? It just describes the situation. The only kind of study that really can prove the point are randomized controlled trials. And those are big. They have to be big. They're expensive, and they're much more tightly controlled on a regulatory level. But those are the kinds of studies that we don't have enough of. And unfortunately, this current administration is sort of rebranding observational studies as real world evidence, which sounds great, right? What we want is to know what's going on in the real world, but it's still that same inconclusive type of study. I think what we really need is for our government, which controls most of the funds for research, to sort of start to ask the questions that we need answered, and then to back up those questions with funding. So,
Yes.
What is the best dose range for cannabis? First of all, I think we can answer that already, but just taking that as a question, all right, we're going to ask that question. We're going to allocate $50 million, and we're going to go out there, and for the next 2 years, we're going to study this, and we're going to come to an answer, and then it's done,
Yeah.
Is cannabis safe during pregnancy? Well, that one's a tougher one because it's going to be hard to do a randomized controlled trial. In fact, I almost wish I hadn't brought it up because of the ethical considerations of pregnancy.
Yeah.
But there are, how much cannabis is too much cannabis? I mean, there are ways to do these studies, but we're not doing them because they're expensive and complicated. And while cannabis was on Schedule One, that further complicated things. We can get there. And I think that's how we best support progress towards a better understanding of its benefits, its risks, and getting that information to percolate out into mainstream American medicine.
Yeah, no, absolutely. And on the tail end of that, I wonder what are your thoughts on data we should be collecting now that we collect on other medications that would help us see if there is an issue happening within healthcare? What do you think is critical data that we need to know?
I think there's a lot of it, but I mean, one of the things that would be helpful is some sort of a we call sort of post-prescribing surveillance, right? So your listeners are probably aware that when medications go through FDA for approval, they go through a series of trials or called phase 1, 2, and 3. And at the end of 3, if they've kind of proven the safety and efficacy, then they're granted permission to be marketed. But there is a post-marketing surveillance, which is sometimes called the phase 4, where there is a mechanism for collecting adverse reactions.
Mm,
The marketing company is responsible for some of that, and then there's some public options where physicians and other clinicians can report that their patient had a bad outcome. We saw some of that around COVID when people were getting texts to, after they got their COVID injection about, how did they feel and were they having any symptoms and that sort of thing. Generally, it's sort of a little bit more under the general public's radar, but that was just an example where I think people saw it. It's harder to do that because cannabis is not an FDA approved medication at this point,
mm,
right? So it is generally my contention that for medicinal use, patients should be encouraged to see a clinician, number one. And number two is that clinician needs to write a prescription, right? Instead of this sort of recommendation stuff that started back in the 90s from California, we need to go into a much more specific approach now, right? So the doctor is then responsible for picking the appropriate medication preparation, dosing, and then communicating that properly to the patient. And part of that process is you write down a prescription. That means the doc has to know what they're doing, right? So
mm,
that's one good thing. And the second good thing is that if the prescription, like other prescriptions, is legally binding on the seller, meaning in this case, the dispensary, then the patient gets what the doctor and the patient have agreed to and not God only knows what else. I
mm.
would say that, again, in my 15 years of doing this, that the largest determinant of whether a patient has a bad outcome was that if they went to the store convinced them to do something other than what I had recommended. So again, I think a prescription is really fundamental to moving this into a more rigorous and therefore better outcome methodology. But similarly, if we can then be that specific up front, then we can start to monitor on the backside to see what's how often does it work? How often do we need to change? What are the negatives? What are risks and side effects? Those sorts of things would be much easier once we know what they were supposed to be getting and doing in the first place.
No, yeah, in my mind, it always goes to the step right before the prescription because the FDA pathway produces the components that we use in a prescription. It produces the dose range, it produces the indication, and I know that the data is available to create some sort of like these are the outputs formulary per se in every state because we do seed to sale tracking, so we know what's available and we know what the doses available in the state are. And I think that that would be a really good place to even start some sort of guidance and conversation about this is what we have, this is what is being used, and then we can start kind of to see the pattern of what medical patients are choosing. Um,
What
because
you're
like I
describing what you're describing is what's in our introduction to cannabinoid medicine course. What are the indications for use of cannabis? How do you give it? How much do you give? How do you titrate? How do you decide when it's working or it's not working? How do you decide when it's not going to work and you need to just say, this isn't the medicine for you? All of that sort of thing is embodied in that course. It's not that we don't have this information, it's that people don't know it and they're not.
No, that is so true. That is so true. It's not that we don't have the information. And I think that that's a good place to kind of like think through an anchor. I did put the specialist website on the ticker and below so people can kind of tap in and connect. And I always like to end with dreaming out loud. And if you could wave a magic wand and tomorrow medicine would be ideally prepared for endocannabinoid therapeutics and cannabinoid therapeutics, what would it look like?
Well, frankly, it would look a lot like everything else in medicine is the thing, right? I mean, we would take it seriously. We would understand the dose range. We would understand who needs it and who is, for whom it might be a problem. And we would have the prescriptions that we were talking about so that doctors and other clinicians could feel confident that when they prescribe it, that's what the patient will get. And then you can continue the conversation over subsequent visits to say, how did it go for you? What happened? And to be able then to either adjust the dose or switch products or whatever based on that kind of knowledge, just like we would do if we were talking about a blood pressure medication or a cholesterol medication. Right? They don't always work for every person, and they don't always work on day one. You have to follow people up and see how things are progressing and discuss with them what they're doing, because sometimes people don't do what you suggest, but also to understand what side effects they may be having, right? Sure, my blood pressure is better, doc, but every time I go to the shower, I pass out, right? I mean, that happens, and that requires thinking about what medicine and what dose and all of those sorts of things. My general thesis here is that cannabinoid medicine is just like medicine. It just somehow, because it's coming in to medicine from this sort of back door, that we have stigmatized it.
Yeah, no, you're so right. Thank you for that. I hope for the day where we are all taking it very seriously, because I think it is serious. And thank you again, not simply for sharing your expertise, for reminding us that good healthcare begins with curiosity. And I feel sometimes our conversations are not about cannabis all the way. They're about how healthcare evolves
Right.
and how healthcare prepares clinicians for the realities that already exist, how we remain evidence informed and meeting patients where they are, and most importantly, how systems continue to learn. Because when healthcare learns and systems learn, the patients are the ones who benefit. I am really excited to continue exploring people and ideas, innovations, building better healthcare, helping us prepare to be more visible. Um, I really thank you for your presence. Thank you for your insights. I think the viewers, if this, conversation inspired a new question or helped you see healthcare a little differently or cannabis a little differently, share this with your colleagues, share this with students, share this with somebody you care deeply about. We really want to improve patient care. And I think that that's ultimately the goal. So keep asking questions, keep asking to be visible, because healthcare can't manage what it cannot see. Until next time, I'm your host, Judith Ledbetter.